Again, we'll take questions. We'll take questions later. We're going to move now from animals to individuals to sort of what we call the environment in the alcohol research field, which is the alcohol policies that exist in any given area. And Toben Nelson is a primary faculty member of the Alcohol Epidemiology program at the University of Minnesota School of Public Health. And this group has actually done quite a bit of the policy research that we use in the field. He has research interests in health policy, organizational change, health behavior during developmental transitions, social determinants of health, program evaluation, prevention of alcohol attributable harm, and violence prevention and motor vehicle safety.
Good morning. Thank you very much. I really appreciate the opportunity to come and speak to this distinguished body, and I'm glad for the invitation. Today I'm going to talk a little bit about some of the research that we've done at the University of Minnesota, and I've done elsewhere in my career, but also reflect on some of the larger review panels and looks at the evidence in relation to alcohol control policies and specifically on alcohol-related violence. But first I want to motivate the importance or why we want to look at policy and where that fits into the larger context of some of the things we've been talking about during this conference. We mentioned my group at the Alcohol Epidemiology program at the University of Minnesota. A lot of great resources on our website. If you're interested, please do visit. We've just refreshed that website. And certainly acknowledge the support we've had for various projects over the years through NIAAA and the Robert Wood Johnson Foundation. Heard a little bit already today about the relationship between excessive alcohol use and violence. Not a tremendous amount of research on the topic related to policy, which I'll talk about in a little bit. Most of the work that I'm involved with in the policy realm really focuses on impaired driving crashes. And there's almost this notion that if we just prevent the impaired driving, we'll be okay. So if we sort of disentangle driving from drinking, then we don't need to worry too much about the drinking outcomes. But of course, there's a wide range of negative consequences that are related to excessive alcohol use. And all of these different kinds of outcomes have been looked at in relation to policy, and that's sort of the broad base of evidence that we're looking at. And I'll specifically mention some of the less extensive evidence around violence, but I think it's very consistent with the kinds of evidence we see for other outcomes. Here I want to argue that a public health perspective is valuable, and be very specific what I mean about a public health perspective. One that is articulated very well, I think, by Jeffrey Rose, a very well-known, renowned epidemiologist from the London School of Hygiene. This really sparked my own interest in sort of common risk factors, common risk behaviors that lead to large population level kinds of harms and things we might be interested in preventing from a public health perspective. And I like to show this slide to my students in class when I introduce this notion. Hang gliding, yes, probably a pretty risky activity, right? But public health problem? Maybe not. Not that many people are involved in the endeavor of hang gliding. In contrast, we have alcohol consumption, which in some populations that I study, they like to point out to me that drinking alcohol is in fact fun. People like to do it. It's a social activity. It's very common, and it's also very risky, particularly when you think about consumption in certain contexts. So that's what I want to talk about here, demonstrate, and these are sort of idealized curves shown for the purposes of illustration here, but are based on quite a lot of data from work that we've done, as well as work that have been done by others. The relationship between consumption and risk of alcohol-related harm looks a little bit like this. I maybe have exaggerated the exponential relationship here at the higher end. It may look a little bit more linear than that. But as you go from low levels of consumption to higher levels of consumption and into excessive levels of consumption, your risk of harm increases. Now, in many populations, the patterns of consumption look like this. So lots of people who don't drink alcohol and lots of people who drink at low levels of consumption, and a very small number of people who drink at the most extreme levels. But the point here is that even in that there is some level of risk at these somewhat lower levels of consumption. And so I won't embarrass you like I embarrass my class when I ask them, where do you think the population level of harms are experienced? And this is for a wide range of different harms that we've looked at in these studies. And the answer that I often get from my master's level students is toward that right-hand side of the graph where all the risk is, right? But the real answer, when we look at population level data, is that the harms happen in this lower, more harms are happening among the lower levels of consumption. And that's predicted by the work that Jeffrey Rose did. The notion here is that because all those harms are focused down on those lower ends of consumption in the population, that not simply an extreme look at the extreme, the high risk parts of the population, but also a focus on the population as a whole. And the prevention efforts really should be focused not only on that high end of the population, but also moving the whole population curve. Again, the notion here from Rose is that a large number of people exposed to a small risk may generate many more cases than a small number exposed to a high risk. And of course, this is very dependent on the nature of those risk curves and the population and the population distribution of consumption. And that's work that's been done by Sam Harper up at McGill. Very important to pay attention to those things. But we've looked in a number of our studies across a wide range of different populations and, where the distribution of consumption differs, as well as across a number of different outcomes, and found this same relationship. Typically, what we do in alcohol research is look at dichotomous variables, and so thinking about cutting things here between those people who consume any alcohol or abstain from alcohol, shown by this green line, and you can show differences in prevalence here, as well as look at measures like binge drinking, which may, in this idealized curve, happen right about here. Again, showing population level prevalence differences and perhaps a much more extreme level measure like an alcohol use disorder in terms of DSM-4 or DSM-5 criteria. A lot of the work that we did here looked at DSM-4 criteria. But when you look at these at a population level, we found that there's evidence that these, at the population level, these prevalence numbers are pretty highly correlated. So the correlation between abuse using DSM-4 criteria and any past year alcohol use is pretty high, about 0.6. And the relationship between abuse and binge drinking at the population level across a number of different populations is very high, 0.8. So the idea here is that abuse, binge drinking, alcohol use are all part of the same distribution. The notion here, again, and maybe I'm hammering this a little bit too hard, in the prevention paradox, is that the greatest risk of harms comes from the most extreme behaviors, but there are very few of those in many or most populations. Many have more moderate levels of risk. And that level of moderate risk is also, importantly, risk. And that the vast majority of the health harms in a community arise from moderate or lower levels of risk. The implication there is that the greatest gains in the population come from incrementally moving the majority. So we have these two kinds of approaches: a high-risk approach, changing the extreme high-risk individuals, identifying them if we can, providing treatment efforts toward them, and then a population-level approach that aims to change the behavior of the majority, and by changing the conditions that shape everybody's behavior. Now, these are often approaches are often played off against each other, which I think is really counterproductive. These are actually meant to work complementary to each other and in synergy, in taking into account both of those different kinds of perspectives. I think one sort of rudimentary theory developed by Alex Wagner and Cheryl Perry when they were both at the University of Minnesota, looking at the relationship of individuals embedded within larger populations and communities. And a lot of focus has been on this end down here, looking at the relationship between drinking behavior and a variety of alcohol-related problems, the things that we'd like to prevent from a public health perspective, and some individual risk factors that may increase drinking behavior or the relationship between drinking and alcohol-related problems for those individuals. But those individuals, of course, are nested within and live within communities and populations where there are wide ranges of availability of alcohol. And the notion here with this theory is that problems that stem from alcohol abuse or alcohol use are primarily a function of the availability of alcohol in those communities. And the availability, whether it's legal availability, whether it's economic availability by low price of alcohol, of physical availability, having an outlet that sells alcohol near you to access alcohol, all of those things are importantly shaped by how the policies that we have and the norms that we have as a society around how alcohol is provided or restricted from being provided to that population. And those conditions really help set up and foster some of these more downstream relationships. So I say all that to say that public policy is potentially important, and the evidence for policy shaping harms and consumption is reasonably strong. There has been a large number of eminent bodies from various government agencies to the book Alcohol, No Ordinary Commodity that has looked at all the evidence related to these outcomes and policy and found very consistent findings. This one is actually the CDC Guide to Community Preventive Services Task Force findings looking at alcohol consumption and found strong findings related to things such as regulation of alcohol outlet density, the days and hours of sale when alcohol is available, taxes, very strong evidence around tax and price of alcohol and consumption and related harms, and came up with these recommendations in terms of regulating and preventing alcohol and consumption and the problems that are associated with it. Some work that I've been doing is looking at how can we create measures of the policy environment in U.S. states And one of the things that we did to advance this was create ratings of efficacy around these different policies. So we actually looked at 47 different policies at the state level. Here are the top 10 list from a group that we brought together of researchers and people who work in this area to look at the evidence and in a Delphi panel process. And partly because there's strong evidence around some of these factors or some of these policies, and not so strong evidence or very little research at all on some others. So taking into account research evidence as well as theoretical strength in terms of the arguments for why a policy might reduce consumption or related problems, and came up with this list of top 10. It's very consistent, actually, with a lot of the reviews that have been done, in part because the panelists that we chose were participants in some of those reviews. And very specifically, talking about the evidence related, this is from one of the reviews that Alex Wagoner did, looking at tax, a very comprehensive look, and has found a relationship, a modest relationship, but a consistent relationship nonetheless, with a number of violence-related outcomes. These were picked from a larger number of more than 100 studies looking at all different kinds of outcomes, but evidence that tax and price strategies are related, inversely related to violence. So the higher the price of alcohol, the less likely there's alcohol-related violence to be occurring in a community or a state. Similarly, that same kind of evidence showing that price is inversely related to occurrence of suicide. A couple more examples here related to outlet density. Strong relationships here. So the higher the density of alcohol outlets in a given area, the more crime and violence of a variety of sorts occurs, as well as more stronger evidence from time series showing increases in violent crime following privatization and proliferation of alcohol outlets. And that seems to be a function of aggregating outlets together. So more outlets in a smaller space seems to be associated with more violence. Again, some evidence, not very strong evidence, around hours of sale. In the interest of time, I'll pass through this quickly to note that this larger notion of these effective interventions that have, importantly, broad reach are the interventions that can have a bigger public health impact. This slide just shows some work that we have in review, and want to impress upon you that we're not moving strongly in the direction of more policies in the U.S. We see increase in uptake in effective policies around alcohol-impaired driving and policies targeted for youth drinking. But the most effective, that top 10 list that I showed you earlier on this black line, have really been flat over the last more than a decade, while the green line shows that policies we judge to be less effective are actually the ones that are increasing in the United States. I'll leave you with a couple of thoughts in terms of moving forward. I think we need more research linking alcohol policy with violence outcomes. We need more sophisticated theory than the basic framework that I showed you that can help identify mechanisms of action related to policy and alcohol-related harms. Studies to link people, their behaviors, and in the context in which they behave, and incorporate some more innovative methodologies. Thank you.
Thanks, Toben. I do want to add one thing. In 2010, the World Health Organization, the member countries, passed the strategies to reduce alcohol-related harm. And since 2010, WHO has been largely following many of the policies that Toben mentioned, and also the ones that are in that CDC Community Preventive Guide, in trying to get them implemented around the world as part of a strategy to reduce alcohol-related harm. This year is the first time, though, they've decided to focus on violence as one of the areas that they're, as well as fetal alcohol syndrome. Those are the two areas they've decided to focus on. The Organization of Economic Cooperation and Development also just completed an alcohol project, a microsimulation model, where they took policies and applied them across different countries to show how much harm you would reduce if you had certain policies in place. But it's interesting to me that they did not look at violence, although we put it on their radar because I called them to ask them if they'd come and present at this meeting, and they hadn't considered violence. So I think it's important that it's sort of just coming on the screen of places like the World Health Organization and the OECD to look beyond some of the more obvious health consequences, such as liver disease and other alcohol-related mortality, and to look at violence or add it to the list. So, you know, for what it's worth, it's moving forward in that direction, and we should have better evidence on how these policies can actually reduce violence in the future. Okay.